Good evening, everyone. I'm Jan Rock with the DCM Foundation, and you've joined us tonight for the webinar called The Heart Transplant Journey, What You Should Know. We're going to get started in just a moment here. Let people join. Again, as always, everyone's microphone is on mute upon joining, just so that we can clearly hear the speakers. If you have any questions throughout the presentation, please use the Q&A feature at the bottom of your screen. Helping us behind the scenes tonight is Justine. And so if you do have any technical issues, just let us know in the Q&A. But we're getting pretty good at this, so I don't think anyone will have any issues. Tonight's webinar is sponsored by Crtds. We're very thankful for their support. If you'd like to check out their website, you can go to www.crtds.com. And we have a lot of information we're sharing with you tonight. We tried to pare it down, but it's really all super valuable, important information. So if you do have further questions about tonight's information, please do speak to your own cardiologist or your heart transplant team. And so we're just, yeah, it looks like a lot of folks have joined. So again, welcome everyone to tonight's webinar, The Heart Transplant Journey, What You Should Know. Again, I'm Jan Rock. I'll be your host tonight. I am the Director of Information and Education for the DCM Foundation. And if you haven't already been to our website, we are at dcmfoundation.org. Great, so let's get rolling. Next slide, please. The DCM Foundation's mission is to provide hope and support to patients and families with dilated cardiomyopathy through research, advocacy, and education. Next slide. Again, an open Q&A session will follow tonight's presentation. So if you do have a question at any point, please enter it into the Q&A feature of Zoom at the bottom of your screen. So let's get rolling. Next. We're going to do a quick poll just to find out who is attending tonight's webinar. Justine, if you can push the poll for us, that would be great. Who's attending tonight's webinar? Are you a DCM patient, family member or friend, a medical professional, or an industry professional? We'll just take a moment. Okay. Great. If we can end the poll and share the results. Great, thank you. So we have 54%, just over half the folks tonight are DCM patients, which isn't too surprising given the topic. Family members or friends, 15%. Medical professionals, we have almost 20%. And industry professionals, 12%. Excellent, thank you all for attending tonight. And so let's continue. Next slide. Great. Thank you. So first, we're going to have a word from Greg Ruff. Greg isn't on every one of our webinars anymore, but it's really wonderful to have him tonight. He is the DCM Foundation Executive Director and Board President, and he thankfully received a heart transplant last July of 2021. So he can certainly speak to this topic. So Greg, take it away. Thank you so much.
Thanks, Jan. And I'd like to introduce today's presenter, Beth Maydosz. And next slide, please. And we are just thrilled to have her with us. And we're just thrilled that she put this deck together. We were working with Gary Hill at Crtds and said, hey, this is something we really want to do as a recent heart transplant recipient. And as I was going through the process, this is information I really wanted to know. And we heard from 10, 15 people that are part of the DCM Foundation patients and family members that this is something they really wanted to know. So Gary reached out, Crtds is great, they're a sponsor, and found Mary Beth. We got together, she put the deck that you're gonna see together, and I was just blown away. It was right on, it was great information, it's extremely thorough, and we're just thrilled to be able to present this information to you. Mary Beth is, as you can see on your screen, a nurse practitioner, a certified heart transplant coordinator, at the Inova Heart Transplant Program. And she has been doing this for 34 years, worked with probably hundreds or at least hundreds, maybe thousands of patients, and was part of starting their lung transplant program. So we're very honored, very thrilled. And Mary Beth, thanks for being here. And we look forward to hearing what you say.
Next slide. So welcome all. I'm here to talk to you about heart transplant, sort of the why, the who, and the how. So first of all, why? What are the indications for heart transplant? So it's indicated for people who have severely damaged or weakened heart muscle, which can be called cardiomyopathy. Some of you are not at this level. Cardiomyopathy can be caused by a heart attack, a viral illness, a long-term high blood pressure. You could have been born with it. It could be genetic. But in any case, the muscle is enlarged. It is weak. It doesn't pump efficiently. And you end up with these symptoms of heart failure that you are aware of: shortness of breath, swelling, and fatigue. Next slide, please. So patients who can be candidates for heart transplant have these symptoms, even though they're on excellent medical therapy. As you know, there are a lot of really good medicines out there now that can help you feel better and live longer. But once those start to not work as well for you, or for some reason you can't take them, then you may be someone who should be evaluated for transplant. People are very limited by their disease, and they have no other choices that are as good as a heart transplant. Heart failure is a chronic and progressive disease. You may be able to do 90% of your things that you want to do in your life, but slowly but surely it might get worse. And when you have that shortened lifespan, usually they say about a 50-50 chance of living a year. That's when people start to think about a heart transplant. Next slide. But the benefit of heart transplant, which I have seen immensely over the last 34 years, is that you get a longer life and a chance to do things you really like. People have walked their kids down the aisle to get married. They've traveled the world. They've written books. They've done sports, and they enjoy their lives. And the first heart transplant at our center lived over 34 years from her transplant. And may I point out, she didn't die from heart failure. She died from COVID. So take care of that. Next slide. All patients have the right to refuse a transplant. So if you go through an evaluation and they tell you that you are appropriate candidate for transplant, you can change your mind at any point. You're not forced into this. You can decide on alternative treatments. So some people just try to do it with medical management. Some people get implanted devices, like you might have heard of a ventricular assist device. Some of you might even have one. And some choose to just take palliative or hospice care and not do any heroics to save their lives. Next slide, please. So heart transplant has a lot of potential side effects, and you have to be willing to understand that and live with it if you choose this option. So the medical risks are, for the rest of your life, you have the potential to reject that heart if you don't take your medications. Failure of the transplanted heart at the time of transplant, meaning you need to be put back on the list. You are immunosuppressed. You're higher risk for all sorts of infections acutely at the time of the transplant, wound infections or pneumonia. You can have heart rhythm disturbances, including a heart stoppage. You can get blood clots. Other organs are stressed and might have failure, like your kidneys or lungs. And of course, there's always death. Next slide. It's a very stressful thing to go through. So some people live with, initially with depression. They can have PTSD. If you have an ICD, you know what that's like when it goes off. General feelings of anxiety and guilt. I want to say at this point, it's important that everybody knows that no donor dies to become a donor. They die and their family makes the heroic choice of giving other people a chance to live. People don't like to be dependent on others, and they are dependent. They need rides. They need people to help them out. And then there's always the fears about finances and your insurance. Next slide, please. So the evaluation, do I need a transplant and am I a candidate? What it comes down to, am I sick enough to need one? Am I healthy enough to survive one? And do I really want this? Next slide. So a transplant evaluation is a head to toe assessment of your entire body. Every patient undergoes similar testing related to consults and education. If they find a particular problem, something that might look like a cancer or a blood dyscrasia or something, they will dig into it a little bit farther and you'll have additional testing and maybe more consults. Next slide, please. Some of the tests you might get are a cardiopulmonary stress test where you run on a treadmill wearing a mask that measures the gases, a pulmonary function test, laboratory tests, lots of laboratory tests to evaluate other organ functions like your kidney and liver, and to look for previous infections or current infections. You get EKGs, CAT scans of the chest, abdomen, and pelvis, echocardiograms, abdominal ultrasounds, carotid ultrasounds. Those are the arteries that lead to your head. They do leg artery ultrasounds and usually a right and left heart cath. Next slide, please. There are screenings and vaccinations that are needed. Once you get transplanted, all things that could lead to an infection are faster because you're immunosuppressed, and cancers can react faster as well. So we like to take care of all those things before transplant. So everybody's got to see a dentist and they got to get dental clearances because their mouth is very vascular. If you get an abscess in there with an infection, it can get into your blood right away. Colonoscopy or Cologuard. You got to make sure you don't have an active colon cancer. If that's something we can take care of before transplant. Mammograms and Pap smears have to be up to date. Everybody gets the hepatitis B vaccine series if they're not immune to hepatitis B already, because after transplant, some of these vaccines don't work as well. And we want to prevent you from getting hepatitis B anytime in the future. Many centers require the COVID-19 vaccines, and they strongly recommend that all caregivers and people who live in the same house with them also get their vaccination series. Annual influenza vaccines, pneumonia vaccines, and now that the Shingrix vaccine is available, that is really important because you're more at risk for getting shingles post-transplant. And then the varicella vaccines, if you've never had chickenpox, if you're not immune to chickenpox, you have to get that before transplant because it cannot be given after transplant since it's a live vaccine. Next slide, please. Reasons why you might not be a candidate for transplant. Advanced age. We kind of laugh about this when transplant first started. Even when I first started, the cutoff age was 55. Now we have people who have had transplants up to 73 at the center I work at. Every center has its own rules and regulations and policies. But keeping that in mind, if you're at advanced age, you should be in really good shape in other ways. So obesity, many centers have a cutoff, what we call BMI. So height and weight gives you your body mass index. Our center does people up to 45. Many centers stop at 35 or 40. Non-adherence. Transplant is really, really difficult to do if you can't follow recommendations, medication lists, you don't survive. So showing up at your clinic visit matters. Taking your meds when you're being evaluated matters. Showing that you can adhere to a program matters. Psychosocial instability. If you don't know where you're going to live, you don't know where your income's coming from, you don't have support, that can be a possible reason why you couldn't get a transplant. Alcohol or drug use, including tobacco. If someone's going to give someone a possible second chance at life, we have to be careful that they're not going to abuse it. So tobacco, ongoing tobacco is a no-go. Most centers now, because the studies have shown that if you can't quit smoking tobacco for 6 months, that you're very likely to go back to it. So most of them require a 6-month non-smoking clause, and they will actually check your nicotine levels. Inadequate insurance. I know this sounds horrible, but transplant meds are very, very expensive. And if you can't afford them one way or another, you will not survive. So they can be $10,000, $12,000 a month. So it really matters that you have adequate insurance. Some centers do not transplant people with HIV. Our center does, but it's based on the fact that you have no virus noticed in your blood, and you take your medication and your white blood count is normal. But if you're too sick with HIV, then you're not a candidate for transplant, especially when you're going to be immunosuppressed and make it worse. That goes the same for untreated hepatitis. Hepatitis C now has an excellent treatment. So if we find that when we're evaluating you, you can take an 8-week course of the medication and be cured from it. Hepatitis B can be a chronic thing, but we need to know that before transplant so that we can put you on medication that keeps it from reactivating. Pulmonary hypertension, that is the pressure in your lungs that the right side of your heart has to push blood through your lungs. So if that's too high, the new heart is shocked by that pressure. And so there are some medications you can take pre-transplant to try to change those pressures and make them better for the time of transplant. Or you might need a heart-lung transplant. Recent blood clot in the lungs is a time thing. We need that to heal before you get a transplant. Diabetes. Diabetes is not something you cannot get a transplant for. What is uncontrolled diabetes. So if your blood sugars are high, your hemoglobin A1C is high, you're going to be put on a program to improve that before you're going to get listed for transplant. Keeping in mind that after transplant, some of the meds make the diabetes worse, and diabetes over time hurts eyes, kidneys, other blood vessels in your body. So it's very important that you get your diabetes under control. We look for peripheral vascular and carotid disease, which is blood flow to other organs. Remember, the plan with heart transplant is just to replace the heart, not anything else in your body, right? So the rest of your vessels in your body still have to be healthy, and blood needs to be able to pump through them, both to your brain and to other organs. We check your kidney and liver disease. Now, some centers do not do multi-organ transplants. At our center, we will do heart kidneys if a patient needs a kidney. However, we don't do heart liver. So if you needed a heart liver, we could refer you to another center. And some centers only do one organ. Cancer, active cancer, would be something we'd have to take into consideration. Some are indolent and wouldn't be harmed by transplant, but others would get much, much worse with poor prognosis after transplant. But you want that all taken care of beforehand. Then active infections, obviously, if we can get rid of the infection, then that won't be a long-term issue. And peptic ulcer disease, we have to get that under control before transplant. Next slide, please. Once all of these studies are done, then a patient is presented in a committee. This is not a one-person choice. Once the evaluation is completed, we meet in a committee meeting, which is called a multidisciplinary team. Every candidate is evaluated on an individual basis. They are evaluated and considered even if they have relative contraindications. Next slide. So who's on the team? There's a transplant cardiologist, a transplant surgeon, a social worker, transplant coordinators who are usually nurses, dietitians, financial coordinators, research coordinators, pharmacists, and any specialists that we might need, like infectious disease or a nephrologist. All of these people weigh in on what they found and how strong you are, how frail you are, whether or not they think you have the support you need, and whether or not you're healthy enough to live through a transplant. Next slide. The committee makes a decision on you're accepted for transplant because they think you're an appropriate candidate and your name will be added to the wait list. You're declined for transplant because they think you're not a strong candidate. That, however, may mean that there's something about you that can be modified and improved, and a plan can come up that said in 3 months, we need to see this, and like you're able to quit smoking, you're not using drugs, you're losing weight, your diabetes is under control. Those can be modified and you can be come back up at committee again. Or if there's something that makes us say that at any particular center that you don't fit what our center does, we can always refer you to another center that might. Like if you needed a heart liver at my center, we would refer you to a center that had heart livers. Or you can be deferred, meaning for right now, we can't make a decision. There's nothing really wrong, but maybe your insurance isn't going to kick in for a month, or you didn't complete all your testing that you needed to have done. The Pap smear is not done, or the colonoscopy is not done. Then you're deferred until the other additional testing and consults can be gotten. And we give you a time frame for this decision. Can you go to the next slide, please?
Great, I will take this slide. So now we're going to do poll number 2. If you could push the poll for us, please, Justine, that'd be great. What is your listing status or that of your family member? And if this doesn't apply, obviously you don't need to answer it. I am currently listed, status 1 to 4, currently listed, status 5 to 7, not listed but approaching being listed, not listed or planning on it soon, or already received a transplant. Interesting results coming in here. So just take a moment and either answer for yourself, or if you are a family member or friend of someone with DCM or heart failure, you can answer it according to their situation. Okay, great. Let's end the poll and I will share the results. Currently listed status 1 to 4, 0. Currently listed status 5 to 7, 8%. Not listed but approaching being listed is 8%. And not listed or planning on it soon at 50%. So this is kind of good long range information maybe for you or your loved one. Already received a heart transplant. This is amazing, 33%. So that's great. That's very encouraging. Great. Okay, if we can stop sharing and we will continue. And Mary Beth, you can just X out of that to continue on. Thank you.
So what does it mean by listing for transplant? Next slide, please. Listing means your name is added to the UNOS national database. UNOS is the United Network for Organ Sharing, and it's an organization that the federal government has contracted with to maintain the wait list and make sure all the organs are fairly allocated based on policy. You also may have a regional transplant community that works on this based on the standards set by UNOS, and they help work with the donor, the donor's family, and coordinating local organ recoveries. Next slide. So listing. If you've been accepted, your insurance company will have to approve your listing prior to your information being added to the UNOS database. And once you are in the UNOS database, you will be notified that you are listed. And anytime there's changes in status, you will be told that your status has changed, including removal from that list. Being placed on the wait list does not guarantee you will receive a transplant. Next slide. Reasons for removal from the wait list. So you're put on, but you come too sick. You wouldn't survive the transplant. You might be taken off. You lose insurance, so you may be made inactive until you can get insurance coverage back. Or inadequate social support. If you become non-compliant, including not showing up for your clinic visits, not doing your medications, then you may be removed from the list. Or the patient just might change their mind and they might want to be removed from the list. You can be listed at more than one center. You have to go through the evaluation process at each center you get listed at. You have to check with your insurance if they're willing to pay for more than one listing. And they have to be within a reasonable distance from each other, because you have to be able to get to either hospital within a certain time period when you get that call for a transplant. And sometimes multiple listings can shorten your wait time. Next slide, please. So there are 7 statuses, and I'm not going to go into them in depth. 1 and 2 are the sickest. Go to the next slide. And it goes to 3, 4, next slide, 4 and 5, next slide. All of them are based on your diagnosis and how sick you are, and if you're in the hospital, and your team will move you up by status if you get sicker. 6 is all the remaining other candidates that are on the list, but are not having any of the illnesses or diagnoses that make them higher on the list. And status 7 is you're made inactive, not currently receiving heart offers. Next slide. When you're on the wait list, aside from your medical urgency status, which you just saw, 1 through 7, these factors influence your time on the list. Body size, body surface area. Bigger people wait longer because they got to find a heart that fits them. Blood types matter too, because blood type O is the universal donor, so it can go to anyone on the list. Whereas if you are blood type AB, you're the only one who can receive that heart. So are you and other people who are that blood type. So your wait list, your time on the wait list tends to be shorter. Being highly sensitized. I can't go into that too much tonight because it's pretty involved, but basically your body has seen something from other people at some time, and you have antibodies against other people. And that can happen sometimes from pregnancy because you've had another person inside you, or from receiving transfusions in the past. And then of course, donor availability. Next slide. Donors are identified wherever they are, and the donor coordinators go and talk to the families. When an organ has been accepted by the donor organization, they then put it out in UNOS, and it goes out to the people who are local, who are status 1 first, and then it goes out to people who are 500 nautical miles from that, who are status 1, and it can go out to 1,000 miles of nautical miles from where that donor is. And then it goes back so that the sickest people closest to the heart, the donor, get the heart first. If no one accepts the organ at any level, it goes farther out. Most donated hearts are, if they're not used locally, are all within the first 1,000 miles, because time matters on the heart. It's got to be 4 to 6 hours from being removed from the donor to being blood flowing through it in the recipient. Next slide, please. Every 6 months, a transplant center where you're listed at has to tell you the most current survival rates and for both patients and grafts at their center, and what is expected nationally. These right here is the Scientific Registry of Transplant Recipients. These are the graft 1 year and patient survival 1 year nationally. And that's what your center should be. They have to explain if they're less than that. And sometimes it's because they took a lot of really, really sick patients, but that's the national standard. And you can always go to the Scientific Registry of Transplant Recipients and look this up yourself. Next slide, please. Waiting for transplant, being healthy and informed. Next slide. Next slide, please. The thing to know is you are a member of the transplant team. You're not just a patient, you're a member of the transplant team. And so you have to, like everyone else, work the hardest you can to make you healthy and ready for transplant. So during the waiting period, the transplant team will follow you routinely. And they want you to know how to monitor yourself. You're going to have to monitor yourself after transplant. That's weighing yourself, taking your blood pressure. During pre-transplant, it may be measuring your urine output, but all of these are important. Take the next slide, please. You need to be as active as you can be. If you can go to cardiac rehab, that's great, or walking every day, because you want all of your muscles to be as strong as they can be going into this. You want to eat healthy, thinking about, like they're always telling you, low sodium, low fat, low carbohydrate if you're diabetic. You want to learn coping skills. And I know that sounds sort of pat, but there's nothing like going through this to stress you. So if you're having difficulty coping with other things, you're going to have difficulty coping with this. Some people learn to meditate, or they take yoga, or they go see a therapist, whatever it takes, or what you find soothing. So learn some coping skills. Educate yourself about life after transplant, so it's not such a big shock when you're trying to learn about it afterwards. Take your medications as directed, monitor your health, and let your medical team know any problems so they can take care of it immediately. Ask for help. Go to the next slide, please. So when a donor organ is offered to you, you're expected to be available 24 hours a day, 7 days a week. Having done this for many years, I can tell you a lot of times we're doing transplants in the middle of the night. And it's really difficult when you have a time crunch and you can't find a patient. You might have to pass them by and give it to someone else. You don't want to leave town without letting your team know if you're listed. And they'll tell you what's an accepted traveling time to the transplant center. You can't say miles, it depends on where you live. But if you can't get to the hospital in a reasonable time, they're going to make you a status 7 until you come back, which means you might miss a transplant that might have been offered to you. Next slide. Where does the heart come from? Well, donated hearts are most likely to function if they are transplanted within 4 to 6 hours of being recovered from the donor, as I said earlier. So we try to keep this preservation time as short as possible. We try to say that if we have to get in a plane, that it's only like 2 hours away, so it's 2 hours back. So that's only 2 hours of time where the donor's heart is not beating, which we call ischemic time. If we have to go in rush hour, a lot of times we'll take a helicopter because we don't want the ambulance stuck in traffic. The donor is a person who has been declared brain dead. That means they have irreversible brain damage. If they're taken off life support, they're not going to survive. And they're not in a vegetative state, they are brain dead. Family of the donor consents to the organ donation, and it's a gift of life. Next slide, please. The organ is evaluated before being offered to your team. So the donor coordinator at the donor site is running tests on that donor. Just like you got your head to toe workup to be evaluated, the donor is being evaluated. Medical history, psychosocial, behavioral, lab work, echocardiogram, caths, chest CTs. We're looking for signs of infection or function of the heart. And not just us, the donor is getting all these for every organ in their body. Once that information is available and offered to a donor's transplant center, the coordinator, the cardiologist, and the surgeon all review that information in UNOS before making a decision on whether or not it's a good organ for one of our recipients. Next slide. So the transplant physicians and surgeons determine if an organ is appropriate for transplant, and they look at how sick you are. So if it's not an absolutely perfect, pure donor, but you are in crisis and not likely to live for very long, they may consider that donor. If you are really stable and at home and it's not a perfect donor, they may not consider that donor. If the organ donor meets what we call public health service risk criteria, we will let you know that. What that public health service risk criteria means is something in the psychosocial history on this donor tells us that they did some risky things in their past that might make them possible to have an infection. However, every blood test that we've done is negative for HIV, hepatitis, all those tests come back negative, even when we're doing the nucleic acid testing, which is the most up-to-date testing for that. But if that person has that history, you'll be notified. So you can make the choice whether or not you want that organ. You have the right to refuse an organ for any reason and continue to be listed on the wait list. Next slide. So this risk criteria, like I said, is what is determined by the CDC as risk factors, not problems with the donor, but risk factors. But all the tests are negative. But even with that, there is an absolutely really small chance that they could give the recipient hepatitis B, Hep C, or HIV. It's not zero. So approximately somewhere between 1 in 10,000, 1 in a million recipients could receive one of these organs and catch an infection. Now, I must say that I've never seen that, but it is possible. But that's something you discuss with your transplant team on whether or not you're willing to accept what we call a risky donor or a CDC risk donor. Next slide. When you accept an organ, it's like having a closed adoption. If you understand what I'm saying, you know that in a closed adoption that the recipients of the baby don't know anything about the parents of the baby and vice versa. And it's the same thing with a donor organ, initially anyway. So you will be told that the donor has risk factors. You will not be told the donor's history. And don't expect anyone to tell you that. That's their privacy. You will only know that we have found all the tests to be negative and that there was some risk behavior done. And your team will give you a recommendation on whether or not they think it's a good organ for you. But you still have the right to refuse it at any time. But keeping in mind, if your physician feels this is a good donor, then you may have a greater chance of dying while waiting for the next organ than you would with that organ. But that's something to discuss with your transplant team. All transplant patients, every single one who receives an organ, gets testing for all of these infections during the first year post-transplant. And should a transmission occur, there are effective therapies available for treatment of them. Next slide, please. Specifically, Hep C positive donors. Now, these are not donors that have risk behavior. These are donors who had actual infection in their blood, active infection. And in the past, many years ago, we would turn these donors down automatically. And then about 10 years ago, really excellent medication for hepatitis C came out. Many of these donors are young and in excellent condition and have excellent hearts, but they have Hep C. And people receive these hearts. Many centers do use these hearts. We tell the patient that it's a hepatitis C donor and they're aware of it and they've accepted that. And then after transplant, they receive 12 weeks of the hepatitis C treatment. And it's an excellent treatment. And we've had 0% patients who after 3 to 6 months have any hepatitis C. So multiple centers throughout the country have this, mostly the large centers, but if your center has this, this will be something they will discuss with you. People wait long times on the organ transplant wait list. I think there was in 2020 was the last tally about less than 4,000 transplants done in a year. And there's hundreds of thousands of people that might need one. So up to 50% of patients may die waiting on the transplant list. So this is just something to think about. Next slide. I've already told you this first line here. It's important to understand that the donor information is confidential and we won't share it. Now, social workers can help you with, if you want to send a thank you letter to the donor family, they'll get it to the donor family or vice versa, but it will be incognito unless both sides choose to know each other, and then that can happen in the future. But like I said, it's like a closed adoption. Organ families donate under the idea that their identity is going to be kept confidential. Next slide, please. So once you're listed and you're getting ready for transplant, it's an idea. It's like being pregnant, keeping the little bag ready to go. And if you're a VAD patient, it's good to have a shower bag and other equipment, such as your batteries to go to the hospital. There's such a thing as a dry run, which means we call you and we tell you that we have an organ. And we have, if you're not in the hospital already, we have you on your way to the hospital. And once you're there, when our team gets to the donor and they look at the heart, there may be a problem and they decide not to go ahead, and we just send you home, which we call a dry run. So you want to be prepared for both that in your mind, but also to get there and have enough equipment to go home, which is why it's important to have extra batteries for your VAD. When they call you, you stop eating and drinking like for any surgery so that you're nothing by mouth. The coordinator tells you where to report if you're at home, and where to park your car. And it's good to think ahead about things like the durable power of attorney, a living will, or medical advance directives, to have those on your chart and with your family if anything should come up. Next slide. The surgical experience, if some of you have had open heart surgery before, so it's the same before you go into the operating room. Members of the team, like the anesthesiologist, the surgeon, they come to talk to you. Some testing will be repeated, including a lot of labs. The surgery requires general anesthesia, so you'll be on a breathing machine for the surgery and during the immediate post-operative phase. The surgeon will perform a sternotomy, that's incision down through the breastbone in order to do the transplant. And they put different drains in to help drain out extra fluid caused by from the operative area. And you got a lot of IVs for medications and fluids in your arms and neck to monitor your vital signs and for medication administration. Next slide, please. Everybody has a different length of hospital stay, but you can expect to stay in an ICU area for about anywhere from a couple of days to a week. And then you can be transferred to a cardiovascular step-down unit until discharge. Some centers have a transplant unit where you go from one side of the unit to the other and never leave the unit, but you usually get a step down in care. During your stay, you'll learn all about life after transplant. You get education from pharmacists and nutritionists and from transplant coordinators on the care of your transplant and yourself. And you want to learn as much as you can before transplant, like sitting through this, because it's much easier to take it all in when you just haven't gone through anesthesia and you might have pain and you're a little stressed. Next slide. So one of the big things about transplant, and you have to understand so you can make the decision on whether or not you want to go through it, is that for the rest of your life, you need to take medications to fool your immune system so it doesn't reject that heart. It knows, your body will know that it's not the same DNA as the rest of you, and we'll think of it as a foreign object and we'll want to attack it. So we give you medications to calm the immune system for the rest of your life, and missing those medications can be life-threatening. You'll start taking those medications during the surgery to suppress your immune system, and you'll take them for the rest of your life. Next slide. One of the ways we check for rejection is something called an endomyocardial biopsy. Since many of you have already had a transplant, you know what I'm talking about, but in most cases, it's what we call a right heart cath or a catheterization into your right internal jugular vein or left internal jugular vein, which is here on your neck. The catheter is moved forward into your heart, and it has little tiny bioptones or teeth on the end of it, and takes tiny pieces of tissue. And that tissue is then reviewed by a pathologist under a microscope to decide whether or not there's rejection or not. The frequency of these differ at different transplant centers. It usually is like weekly at first and then monthly, but many centers do different protocols on that, and that would be your center. After 55 days, there is a blood test that can replace some of the biopsies in most patients, and that's what the one that Crtds uses, called HeartCare. Next slide, please. So before discharge, you have to know how to care for yourself, which means medications, names, dose, and purpose. And you're going to be asked that every single time you come to clinic. You're going to need to know infection control measures. It's going to be important about your diet. Low fat, low sodium, just like everybody else, keep the rest of you happy. And the funny thing is you really do have to give up grapefruit for the rest of your life, because it actually changes the metabolism of transplant meds in your liver. You're going to need to get onto an exercise plan, and they're going to teach you how to do that. It's an interesting thing when another heart is placed in your body. We have to cut the big nerves to your brain, so it's called the denervated heart, and you have to learn to exercise differently when you first are transplanted. There's a follow-up schedule for all your biopsies and clinic visits. Like I said, some of the biopsies are weekly initially. Different centers do this differently, but plan to be seen frequently in that first year post-transplant. And anytime you have any problems, they're going to want to see you. You need to know all your emergency contacts, have all your prescriptions. At our hospital, one of us, our heart transplant nurse practitioners who take care of you as outpatients, we all go to your room before your discharge and go and have the medications delivered to your room. And we don't let you leave unless every medication is in that bag, so that you can't go home and not have what you need. Post-transplant teaching is done with the transplant team. That's done, like I said, with nutritionists, physical therapists, the pharmacist, and the transplant coordinators. Next slide. Long-term follow-up. So like I said, initially it's frequently, and every center is different. In my center, it's weekly for the first 8 weeks, then every 2 weeks until you're 12 weeks out from transplant, then monthly for the first year, and then every 3 months the next year, and on and on. But every center does it slightly differently. But once again, you're not bionic. We've only replaced your heart. So you need to continue to see your primary care. It's important you also see a dermatologist at least annually to get routine skin checks, because the transplant meds make you at increased risk for skin cancers. But the primary care is still going to take care of things that are not related to your heart, like your prostate, or order your mammogram. All right, so you need to keep close contact with your primary care. And if you don't have one, you might want to find one you like before transplant. Now, many people like to use over-the-counter herbs and medications and they think that because they're natural, they may be safe. But actually, many over-the-counter herbs and medications interact really badly with transplant meds and cause great harm. So once you're transplanted, you don't want to put anything, not a vitamin, not a herb, or not another medication across your lips without checking with your transplant center. Other physicians who are very knowledgeable about their own field of medicine and use medications frequently, which are the best medication for a particular treatment, that medication may not be the best medication for a transplant patient. Next slide. Your keys to success are to go to your transplant appointments, take your medications, maintain your insurance so that you can get your medications and get your care. Notify the team when problems first occur. Please don't wait until you're so sick the only place to go is the emergency room. Take care of your whole body. I tell my patients I'm trying to make them perfect. I can't do that. But if you don't take care of your diabetes or your hypertension, You're not going to be the patient that lives 34 years post-transplant. Next slide. So, and while you're waiting for transplant, you want to keep up to date on all this routine care. So if you are due for COVID vaccines, make sure you get them. Patients, post-transplant patients are now up to 5 COVID vaccines. But the COVID vaccines work less on them after transplant because they're immunosuppression. So as much COVID vaccine that you can get prior, the better off you are. You get your yearly influenza vaccine, pneumonia vaccines. If you're not immune to hepatitis B, you go through the hepatitis B series. It works better pre-transplant. You want to keep your teeth up to date. If you're due for a colonoscopy, get your colonoscopy. If you're due for your mammogram and pap smears, get those done. Next slide, please. There are a lot of places you can look for more information about transplant. These are just some of them. Most transplant centers have their own transplant support group that you can be a part of. And you can meet other people going through the same thing as you. Next slide.
Excellent. Great. Thank you so much, Mary Beth. It's been wonderful to have you share your knowledge with everyone. We do have some questions that have come in, and I do encourage folks to please drop any questions into the Q&A feature at the bottom of your screen. Let me roll through some of these with you here. So the first question, Mary Beth, does insurance decline your transplant medicine coverage?
Well,
depends on your insurance.
Exactly. So when you're choosing an insurance and you know you're going to be on these transplant meds, and when you're going through your transplant education, we actually give you a list of the transplant medications that may be involved. You can check to make sure it's on the formulary for your insurance. If not, you may want to change the kind of insurance you have or take a different level of insurance. But it can say that that's not what they do. Now, one thing I want to tell you, if you have Medicare at the time of your transplant, Medicare B will pay for 80% of your immunosuppressive transplant medications for life. If you do not have Medicare at the time of your transplant, even if you get Medicare later, it will not pay for your transplant medications.
Wow. Okay. Okay. Good to know. Thank you. What is the time frame to reach the hospital when they call you with a heart available? I think you answered this a bit during your presentation.
Well, our center, it's 3 hours.
Okay.
I can't say what other centers think is reasonable. If you have your own private jet, they might let you go farther, but most people don't have that.
Most people do not. I do have a question that came in from Tina before the webinar, and she said, is there an actual age limit when a heart transplant is not possible? And I don't know if there's an upper limit. I know you mentioned 73.
I don't, some centers have an absolute cutoff. They might say not over 65, not over 70. We look at every patient. I mean, if you know, when you look at people now, you say, wow, that person is 72. They
Right.
look older than that person that's 52. And usually when we're talking about old, we're not talking about wrinkles. We are talking about what the rest of their body is doing and how frail they are. So if you happen to be a 71-year-old marathon runner with perfect kidneys and perfect liver and good bone structure and no dementia, you might be an excellent candidate where the 65-year-old wasn't. So I think that's something you always want to bring to your transplant center, and you don't want to make an assumption about.
Okay, excellent. Thank you. What new technologies are in process to extend the 4 to 6 hour of heart time limit from the time it's taken?
Well, there are actually in studies right now, mechanical like pumps. So they go to the donor center, they put the heart on a pump, and they're hoping that will extend the life of the organ, but that's really kind of in research right now. They use a similar kind of pump not exactly, but with lungs as well. But we haven't gotten to the point where that's routine.
Okay. Is being gay considered a risk factor?
For the recipient or the donor?
For the donor heart, I believe.
It would be considered, yes. It's not being gay. It's, men having sex with men essentially is what is a risk factor. But once again, you check for everything, and so it would be listed as something as the PCS high risk, yes, or
Okay.
not high risk, risk.
Okay. How are important genetic results shared with doctors if the family learns of relevant genetic issues?
Well, if you have a relevant genetic issue, tell your physician that. I mean, if you're talking about the recipient, because it might make a difference in how you are treated both pre and post-transplant. There are some things pre-transplant that can, maybe medications that can be given that can prolong the time period before you need a transplant. And post-transplant, certainly if there's something genetic that we can, that we haven't taken care of by replacing the heart, maybe we need to know that. Something like Fabry's disease, where people take Fabrazyme post-transplant, or people who have amyloid take tadalafil post-transplant. Yeah, it would be something you should certainly tell your physician if you know there's a genetics.
Okay, excellent. Why do you need to continue a low sodium diet after transplant?
Well, not everyone truly has to do that, but initially you certainly do. Most transplant patients do have hypertension post-transplant. Not all, but most do. And we have them on antihypertensive. And as you know, sodium makes hypertension worse. And initially post-transplant, people have gotten a lot of fluid in the hospital. They've been through a lot. They've been on they tend to be very puffy when they go home. And they may need diuretics, but it's nice not to aggravate that by adding high sodium to your diet.
That's a good way to put it.
And, I don't need a heart transplant, but I eat a low sodium diet because what we all should be doing anyway.
Right. How long is the actual transplant surgery?
Well, the main part about sewing in the heart is less than 4 hours usually. Now, people can have, if people have had surgery before in their chest, they can have adhesions, and they've had a VAD, so they could have bleeding problems. So the time in the OR can be extended even though the heart is in and pumping. So that, I would say, it's hard to tell. People have been in the OR for 12 hours, but the heart itself is sewn in and beating in the less than first four. Fascinating.
Jim asked if a copy of this presentation will be available online, and I can say yes, it will. And that will be included in the DCM Foundation website under our webinars portion. We will also be sending out a recorded version of this after the event within 48 hours. So let's see, how much control does the insurance company have in whether or not you're approved for a transplant? That's interesting.
The only thing they have is whether or not it's in you're allowed to have a transplant on your insurance. If your insurance stipulates right in the insurance that you chose, it does not cover transplant, they don't have to do it. But they can't, if your insurance covers transplant, when a transplant team says you need it, they really can't say you can't get it. They may say you can't get it at the center that you want to get it. They may say you have to go to a center that they choose.
Okay. Emma asks, what if you're not listed, but the diuretics are slowly causing damage to your kidneys? Is there anything you can do to preserve your kidney function and still keep fluid off?
Well, Unfortunately, diuretics are needed. And you're right that there is a little wear and tear. Keeping your heart and the rest of you doing all right can be difficult to the kidneys. But the important thing is to remember that low sodium diet really makes a difference. You need less diuretics if you actually follow it. If you, just follow your medications as best you can and try to balance it all out. Talk to your doctor about if you have that fear. That's something to really speak to your physician about. Maybe they can look at other medications that you're on and balance that all out for you. But the one thing you can do is eat that, really just take that low sodium diet that nobody wants, but I'm telling you, you get used to it.
You get used to it. And again, just a reminder to everyone to always consult your own physician about any of the information provided on any of our webinars, and particularly this webinar tonight. Stella asks, do your financials decline you from being on the wait list? I think that means your financial situation.
We have patients on Medicaid that get transplant. So it's not necessarily your financial situation, but Medicaid will pay for the transplant meds. Do you have Medicaid, or do you have insurance that will pay for the do you have a home to go to? Whether that's living with a family member or your own apartment, you have to have a place to live. You have to be able to afford food, and you have to be able to get your medications. Otherwise, it doesn't matter to us whether you live in a mansion or you live in an efficiency apartment, as long as you have a safe place to go and you can get your medications and you have food to eat.
Okay. Do you see hearts being made with your own tissue in the near future?
Not the near future, but it does sound really interesting. There's a lot of speculation out there that in the future will happen, but it's nowhere near fruition. So not in the near future, no.
I'm always reading and learning about some of the latest advancements. And it's really fascinating what's coming down the line, but you don't know if it's 5 years or 15 years, right?
Right.
Jennifer asks, what will happen if the transplanted heart has been rejected by the body despite the anti-rejection medications?
Well, we have really great medications right now. So in general, if you remember, I talked about antibodies against the donor. So that puts you at, if you have those, that puts you at higher risk. If you have those kind of antibodies, nowadays we can isolate those in the donor and yourself and say, oh, this is not a donor for you, right? We can pre-treat people with medication that's stronger than some of the stuff we give everybody else. And we treat rejection. Now, yep, there's different levels of rejection, and many people get rejection and we treat it and it goes away. In the situation where this sort of seems to be describing, where it's the ultimate rejection, unfortunately, that would be the situation where we would probably want to put in a total artificial heart on somebody and relist them for another transplant. Or if they're struggling along, but the heart is not totally gone, we might put them back on ECMO and relist them for transplant. But that's a pretty dire thing. And luckily, it doesn't happen very often.
Okay. All right. Excellent. Thank you. How long after transplant are you back to normal, depending on how you describe normal?
Well, if you can take a whole year from work and life and just take care of yourself, that's wonderful, but most people can't. So a lot of people go back to work at 6 months. We send people to cardiac rehab at 3 months post-transplant. Once the sternum, that's the big thing, the sternum is healed and they've gotten a little bit more ambulatory and feel energized, then we send them to cardiac rehab so they can exercise with people that can cheer them on and get them to do things that they might be scared to do without that. And they realize that they're doing well. Sometimes we have to slow people down at 6 months and tell them, no, we don't really want you to do that yet, because they're feeling that well. But I would say somewhere between 6 months and 1 year, people feel most people feel much, much better, and way better than they did before transplant.
Okay, that's great news. Our services offered at most hospitals to assist in all areas of preparing for a transplant. So psychological, financial, is there, I mean, it depends on the hospital, I would assume, but is there kind of one place that you go that helps you navigate all of those things?
Every transplant center is required to have a pharmacist, a social worker, trying to think, dietitian. We have support. They're required actually to be able to have the transplant center. So someone is given that role at every transplant center. So if you have psychosocial issues that come up, there's a social worker there for you to talk to. If you want to talk about your meds, you can talk about them with the pharmacist or your transplant coordinator, of course, your physician. The dietitian can teach you about foods and she works on frailty, making you a stronger person pre-transplant and post-transplant, and helps lose weight or gain weight. And all of them are available to all the patients at the center.
Okay, excellent. Thank you. Are CRTDs removed during transplant surgery?
Yes.
Okay.
In most cases, we remove ICDs, pacemakers, obviously VADs. We review anything that goes into the heart gets removed. Occasionally, we do have to leave pacemaker wires that go through the veins because they actually grow into the wall of the vein and it would hurt you to pull them out. So sometimes wires are left in, but that's about it.
Okay, excellent. Thank you. If anyone has any remaining questions, just drop them into the Q&A. We have a couple more quick minutes here. And if you have a question for Greg Roof, who's already gone through a heart transplant, he is available as well. But Mary Beth, is there anything else that you would like to expand upon? We have a couple of extra minutes, which is a rare instance. So feel free.
Especially for me, I always talk a lot. I can't tell you enough. The two things that I find that patients waiting for transplant and right post-transplant need to know are, one, when I say that you're part of the transplant team, I can't tell you how important that is. I tell my patients, you're the only one with you 24/7. And when I say take your vital signs twice a day and you think, oh, this is a pain in the neck. Well, the day that you're sick and you take your blood pressure and you don't know if it's your normal or not, that's the day I have to tell you to go to the emergency room because I don't know how sick you are because I don't know the change, right? So it's important. It's really important to be a member of your own team. So that's one thing. And the second thing I like to tell you is not everyone, but a good bunch of patients come to me and they after transplant and they have this feeling of guilt or of survivor guilt, and they feel bad. And once again, as I said, I always say, nobody died to make you live, okay? It wasn't, nobody, they weren't thinking about that. Nobody made that happen. These unfortunate people died. And instead of just burying that lovely heart or kidney or lung or whatever, this family did the brave thing and said, I want to give somebody else life. So it's a gift and it's nothing to do with you. You didn't do anything to make it happen. You just have to accept it as a gift.
No, that's a great way to put it. And I just want to remind everyone, if you want to register to become an organ donor, anyone who's on from industry and so forth, go to organdonor.gov and you can register there and encourage your family members, your friends, your children, when they get their license, when they're 16, encourage them to become organ donors because it's really one of the most wonderful things you can do, truly the gift of life. We do have one additional question. Christina asks, is race considered with transplant donor and recipient?
No.
Okay, great. That's,
Jan, if I could
please, yes.
sort of chime in one last minute. Again, Mary Beth, thank you very much. It was wonderful. There's some tough, scary information in it, and it's true. It needs to be presented and talked about. But, again, as an example, one, I'm 11 months today, transplant. I have felt it's no walk in the park. It's not easy. I don't think it was terrible. but I'm 11 months post-transplant. I feel better than I have in 10 years. I have more energy, working 50 hours a week, exercising. And you know what? I'm going to see all my grandkids on Friday. And so life is good. It's difficult. It can be a little scary. The information can be a little tough, but it is a wonderful opportunity. And for most people that I know, they're getting better at it. The outcomes are getting better and better and better. People are living longer, healthier. And, you know, it was a great option for me, and I'm so happy I did it.
Oh, thank you, Greg. And we're so glad you're here.
You didn't say that this afternoon.
We'll take one final question. How many pills do you have to take after transplant? That's a great question.
Greg, how many pills do you have to take?
So I'm only taking probably about 20 a day now. I was probably 35, 40 in the beginning, but they backed off on some of my immunosuppression and just some drugs they just sort of take out. I would say 20 a day, you know, probably 12 in the morning and 8 in the evening. Yeah, easy. It's not that big of a deal, you know. You just take some water and take your pills and go on. So probably 20. I don't know if that's 11 months, if that's normal or not. So
Yeah, I mean, there are prednisone is one of the ones you take earlier, and that's the dose is tapered down and off in most centers. And then you have to, some medications are on for a year to prevent certain kinds of infections. Some are only 3 to 6 months to prevent infections, and some are to prevent you from having ulcers. So once you're off other medications, we take you off of those. Yeah. And so, but you know, things get added on. You get older, you get hypertension. So then you've got a blood pressure pill, or, you know, there's other things, or you need a thyroid pill. That doesn't have anything to do with your transplant, but you have a low thyroid. So to tell you the exact amount of pills everybody has to take. And of course, and Greg will know this too, that everybody metabolizes some of these drugs differently. So like tacrolimus, which is one of your main transplant drugs, we base that on your blood level. So the different patients shooting for the same blood level of, say, like 10, one patient might have to take 15 milligrams twice a day, and one might need to take 1 milligram twice a day, but they get the same blood level just because they clear it through their liver so much faster. So to tell you exactly how many pills is hard, but there's a lot in the beginning and it gets less, but it's never going to be none.
That's a great question and a good response. And when you said clear it from the liver, I think that this is a good question to wrap up with. Can you drink wine at some point after transplant? Well,
I always tell patients 2 things. One, if you had a problem with drinking before, we didn't take care of that, so don't drink again. But number 2, we tried not to have them drink in the first year at our center. Different centers have different rules, and that's something to speak about with your physician. But as Greg can attest, in the first few months, there's a lot of stuff going on, and wine or any kind of alcohol can actually interfere with how somehow you metabolize some of the meds, and we just don't need anything else in there. And I tell the patients, you need your liver and you need the drugs, you don't need the alcohol for right now. But usually by 1 year, we tell them, you know, never binge drinking. It's never that have a 6-pack in front of the television, but, you know, a glass of wine with dinner, a cocktail with friends. Then we say usually say that's okay.
Okay, great, excellent. Thank you so much. That's all the questions we can take for tonight. I just want to thank you so much, Mary Beth, for this incredible information you've shared. There's a lot jam-packed in here, we know. Again, please, for any patients out there, please feel free to talk in more depth with your own heart transplant center or your cardiologist about the information that we shared here tonight. Thank you to CareDx, our wonderful sponsor of tonight's webinar. And thank you to Greg for being on and joining us and sharing his story as well. And we want to give a big shout out and a thank you to all of our generous sponsors whose names you see there on the screen. Again, just a reminder, without their help, we wouldn't be able to bring you all of this incredible information. Next slide. For more about dilated cardiomyopathy, please visit our website, dcmfoundation.org. And to learn more about CareDx, please visit caredx.com. You can also follow us on social media for regular updates, Facebook, Instagram, Twitter, LinkedIn. If you haven't done that, I strongly encourage you to do so, especially on Facebook, because a lot of great information is shared all week long there. And next slide. And last and not least, we would ask that you hold the date for our next webinar, which will be Wednesday, July 20th at 6 p.m. Eastern Time. The topic is DCM gene therapy advancement at Tenaya Therapeutics. So again, thank you all for participating tonight. Thank you for your questions. And thank you, Mary Beth, and to Justine behind the scenes helping us. It was a great event tonight. To everyone out there, stay safe and be well. And we hope to see you next month. Thanks, everyone. Take care for now. Have a good night. Bye.